And we are going to do our one question panel because this is all about talking. Oh, these chairs! This is the first time I've sat down all day. We talked about payers from the health insurance, the MCO angle. We've talked about payers from the federal and state government. Now it's us, philanthropy. So, do we have Dr. Bluebird Jernigan with us? Coming up on Zoom probably. So I promised this would be two questions. First question is, you want name and where you're from.
Okay. I'm Valerie Stewart with the Blue Cross and Blue Shield of North Carolina Foundation. So we are a statewide corporate foundation.
Okay, it looks like this mic is working.
Okay, this one works, great. I'm Kate Masuch. I'm with Novo Nordisk, so a pharmaceutical company, but I am the director of their social impact giving.
So my question to you, Valerie Stewart, you are, we've actually had 3 Valeries in this convening, and it's gotten very confusing. Tell us a little bit about the project you're doing and why the foundation chose to go at it, funding food as medicine at the sort of community infrastructure level.
Great. So I just want to invite you all to North Carolina, or to at least visiting and understanding what is happening in North Carolina that is different. So we are funding the capacity building and infrastructure needed for community-based organizations to become a partner of choice for healthcare. So what our point of view is that community-based organizations are doing this work. They do have the trust in community. They have the relationships in community. They're providing so much more than an intervention. They are more than a food box. They are welcoming, inclusive, relational people that are providing solutions and more than just food. So it's, connection, social isolation, all the things that we've been, talked about all day. So we have 10 that we're funding. We're trying to work on how do they strengthen their ability to partner. The evaluation that we're doing is qualitative, and it's really about what is it that makes a community-based organization a strong partner and a partner, again, of choice for healthcare. So what's it going to take? We're trying to understand the healthcare side, we're trying to understand the community-based organization side, and really help continue to make the case that community-based organizations have a role to play in healthy food prescriptions and food as medicine interventions.
That was a beautifully succinct response, and I lied. I do have a follow-up question. Is there an economic component by choosing to invest in the local community FIM infrastructure rather than saying, well, it'd actually be cheaper and easier and scalable to just go through Amazon? What is that component? Is there an economic component that if you're not officially measuring, at least is of interest?
So this was a great debate at our foundation because the scalable model is certainly what insurers, and I am tied to an insurer, and there's a lot of work being done that we're trying to influence the insurer around this topic. I think it's that, we have been investing in community-based organizations for over 20 years. And again, we believe that they're a vital part of a healthy and thriving community, and that they will be there, whether we're calling this food as medicine or healthy food prescriptions. Again, they've been doing this work, and they're just not being funded for it. So we have to figure out some new financing and funding mechanisms to make this possible so that some of their work is more, whether it's sustainable or durable or regenerative, whichever words you want to use. So we feel like they have a role to play. We were intentional, I guess, in saying that we were not going to pick the one model and anoint that as the thing to scale. Different programs are obviously in different places of the spectrum, as well as, they're meeting their community in different ways. So many of these programs were built organically. They may never scale, but they may be just that amazing community partner that can do this work with their local providers or their local hospital system. And so as long as that's meeting that community's needs, I think we're trying to honor the difference that we're seeing in communities across North Carolina. That's why we chose 10 that were already community-based. And again, working with them over the next 3 years to really, just to continue to strengthen them, even after we're gone, after this funding may dry up. We do have the Medicaid 1115 waiver, and again, we're trying to make the case that these community-based organizations should be in the partnership mix.
Unfortunately, you said 1115, so that triggers one more question, because this is a question on everyone's mind. It's seen as the holy grail for states if they get that waiver. Food as medicine is solved. What's your thought?
No. Simple answer is it won't be. We are trying to demonstrate what is possible, but it's going to take more collaborations, which we've heard today. It's going to take more partnerships. It's going to take more braided funding. It's going to take different value-based payment models. So, we have a lot of work to do. I think it's a great step. We're about 5 years in, and we have a lot of lessons learned that we're still learning and we're still in the middle of.
Thank you. She got more into 5 minutes than I think I could get into 5 days of talking. That was wonderful. I'm going to literally pivot over to my twin here, Kate. Novo Nordisk, tell us a little bit about how your program area chose to start investing in food as medicine, and then particularly in tribal communities.
Yes, and I'm joined by the other Valerie, Bluebird Jernigan, here on the screen. I don't think she introduced herself, but she is definitely the star here, so we'll certainly give this over to her in just a second. But I started at Novo Nordisk 2 years ago, and before getting there, they did not really have a strategy in terms of how they were investing in community. So coming in, my partner in crime and I designed this, very broad, mission for the work that we're doing. So that's reducing the burden of chronic disease for vulnerable populations. The idea of that was really that we could sort of take a look at a bunch of different types of programming and different types of partners and figure out, what are going to be the best ways to invest. So in the last 2 years, we now have 26 projects across 11 states, one of them being Valarie. And I will just tell you that a lot of this has been a learning journey, and I continue to be, humbled to be able to be here with you all and learning from what you're doing. But food really was the thing that came to the top in terms of, we need healthy food for communities to be able to even start to think about having better health outcomes. And so we're investing in a number of different types of programs, not just food as medicine. And I guess one of those being Valerie's program, which is working in Oklahoma with 5 different tribal communities. And I'm going to let her talk a little bit about that project, and then also about maybe what it's like to work with us, Novo Nordisk, and sort of what the partnership has been like.
Great. Hi, everybody. Thank you, Kate. It's great to be here. I'm Valerie Bluebird Jernigan. I'm a professor of medicine and rural health at Oklahoma State University Center for Health Sciences, and I direct the Center for Indigenous Health Research and Policy there. And I'm an enrolled citizen of the Choctaw Nation of Oklahoma. And the projects that I'm working on with Kate and Novo Nordisk, we're working on what we're calling the Indigenous Foodways and Health Initiative. As Kate said, we're supporting 5 tribal nations in Oklahoma to identify and really spotlight and elevate really organic, authentic, grassroots, community-based initiatives that focus on supporting food sovereignty and the transmission of cultural knowledge and traditional foodways across generations. And we are not really prescribing what food sovereignty looks like in each of those sites, but really relying on the tribal nations to tell us what is working in those communities and what they'd like to expound upon or, really extend and build in those settings, and planning with them evaluation measures that meet funding needs as well as the needs of the community and also policymakers. That's been a big focus for me in the last several years, working on different policy committees. And so I'm very interested in thinking about how food sovereignty as a concept, as a movement in tribal nations, can really demonstrate measurable outcomes on the health in tribal nations. So that's the work we're doing, and it's great to be here. Thank you.
I'm sorry, two Valeries. Valerie on Zoom, Dr. Bluebird Jernigan. Can you tell us a little bit about what it's been like working with Kate around what type of evaluation metrics make the most sense in that they bring value to the tribal community members first and foremost, and then secondarily value to Novo Nordisk, with all respect. Does that make sense?
Sure. Novo Nordisk and Kate, who's our program officer, have been really flexible in terms of what their expectations are with regards to health outcomes, to the measures that they would like to see. And I would emphasize that's a conversation that Kate and I had very early on over the course of several months of building a relationship and really examining if this would be a good fit. What do they want to fund? What types of work do we do that we think would fit that? Do we evaluate and could we evaluate outcomes of interest for them? We were very interested in looking at both process and outcome measures. The tribes have emphasized the importance of things like cultural knowledge, language, traditions, increase in food sovereignty activities, but the tribes are actually really interested in clinical outcomes. They're interested in changes in blood pressure, changes in dietary intake. They're interested in changes in A1C levels for diabetics. And so there really wasn't as much of a difference in terms of what both of those parties were interested in looking at. But I think that was because the communities that we chose to work with for this particular initiative have a pretty good amount of capacity to conduct research, and most of them are very long-term partners of us. So we've worked with them for many years. The trust has been built. I think in some of these early types of partnerships with tribal nations, it's not that the tribes are not interested in those clinical outcomes or those types of more Western measures of change, but they need to develop that relationship with the researchers and understand that there's a track record of respect for data sovereignty, respect for tribal sovereignty, and following of all institutional tribal review processes. So the conversations were pretty candid with Kate, and she and I really talked about, let's make sure that we both get the needs met of both the communities as well as Novo Nordisk. And it was pretty easy to find that happy medium and that fit for both of those parties.
Well, thank you so much. You teed me up perfectly for the last question to you, Kate, which is you've kind of mentioned in your role, you sometimes had to do some internal learning within your company about helping them understand the very community-based work that you were funding. Can you talk a little bit about that?
Sure. I think I've been actually pretty lucky in being able to sort of, formulate the way that this has rolled out in terms of like who we've invested in. And as Valerie said, kind of the candid conversations up front. I mean, honestly, we are still working out what our longer term measures are going to be. At this point, it's really just outputs because, we've only been doing this for 1 year. And my leadership has given me the runway, I guess, because they have a little bit of understanding of of tribal communities. I mean, I guess the vice president of public affairs, which is where I sit in the organization, spent some time on a reservation. And so has actually been a bit more open than some about the fact that I'm not going to be able to define exactly what this is going to look like up front. Like, it's an investment that we're making in the community and the development of the relationships. And what we're really looking at is food and ultimately health, how that's going to improve health. But how we get there is probably going to look a little bit different in every one of the scenarios. And I think that has hopefully been why some of the grantees that we've been able to partner with, because I partnered with Valerie in Oklahoma, and then 2 different tribes in South Dakota, 2 in Washington State, and now 1 in South Carolina. So really that expansion, and I think has came out of the fact that we're able to be open and flexible. So I think it's been exciting, and I'm curious to see where it goes. And I think people are open and wanting to have a better understanding of what does it actually look like to work with tribal communities, because there's a lot to learn. I think, especially when we think about getting back to the way that we used to farm food and be connected to the earth, and understand where our food comes from. I think there's a ton to learn from Indigenous communities, and so I'm so grateful to be able to fund and work with them.